Today we're going to be covering module number 3, which is titled Patient Assessment. And today I have with me John Stump, who will be assisting in delivering this module. You ready to go, John?
I'm ready.
Okay.
All right, guys. What we'll be doing is going through a patient assessment, and step by step as we go through this. We'll be reading through the chapters here, and we'll be touching on a few other details that we want you guys to check as we go through this. Also, we have about 3 videos that we'd like to touch on, and one at the very end that when I come around to do your evaluations is the one that we will be working off of. So let's go ahead and get started.
John, before we go, as far as the practical exercise goes, my plan is to send out the National Registry skill sheets for patient assessment. And the video that we're going to insert at the very end of this basically covers the steps associated with doing a head-to-toe, doing your initial assessment, your general impression, and going through it. So it'll be a good review for everybody to go over.
Okay, sounds good. All right, so our slide here is patient assessment and components. Remember, on the scene size up, starts as soon as the call comes in. Okay, whether it be cardiac, respiratory, abdominal, shooting, stabbing, vehicle accident, whatever it is, as soon as the call comes in, that's when our scene size up begins, because we think about what we're going to do when we get there. You're going to identify your initial threats, life threats, if there are any, vehicle accident, structure fires, what they may be. If we go to an EDP patient, attempted suicide, we never know. So remember, your scene size up starts immediately when the call comes in. Once you get there, you're going to identify your initial threats, like I said, to the patient and yourself. Remember, your safety is the utmost priority. Okay? Once you get there, you're going to do your physical examination, your vital signs. You're going to gather as much history as you possibly can, and you're going to prepare the patient for transport. You're going to assist whatever medic unit you have there on the stretcher, and get them ready to get into the rescue. And then if you happen to be one of the riders, you're going to hopefully help them with the ongoing assessments. Okay? So then we go back to body substance isolation. Now, we all have our new nitrile gloves that we started carrying about 1.5 years ago, latex free. Hopefully everybody is happy with those that we have. Those shouldn't be any problems with patients who have any tolerance to latex. So we have those. Everyone should have eye protection. If you don't, get with me and we'll make sure that we have those. I try to keep extra pair at each station. Masks. Remember the masks. Some people put some extra ones in the medical kits. Some of them carry them on themselves. The boxes are in the trucks, so that shouldn't be a problem. And gowns. With the gowns, we have a total body isolation kit that's in the medical kits or in the medical cabinets in all the trucks. So if it warrants that we have to have one of those, they are there.
John, I have a question.
Yes.
EMS on eye protection. I know we recently had a call where someone said they may have gotten some blood splashed on them or spit in their eye. Does EMS routinely wear eye protection on all their calls?
Some do. I know that there are some medics that have the masks with the face shields. We did have those for a while, but the problem is they would get crunched or they would get thrown into a cabinet or whatever else, and they would get destroyed. That's why we went to the glasses.
Okay, so the glasses on all the trucks?
We should have glasses on all the trucks. If we don't, I need to be notified, and then that way I can get more of them. I know that Greg Van Anima told me the other day about another carrier, and he's going to, as they come across, if I need to buy more, he'll let me know.
Okay, so it's important that we have all these tools and that they get used on every call. Okay.
Absolutely. Okay. Move on here. Scene safety. Again, remember, our personal safety always comes first. The patient is always secondary to us. If we're hurt or something happens to us, we are going to be no good for the patient that was called for. Okay, so we always look for possible dangers when whoever the driver of the truck and the officer of the truck, always look as you pull up on scene. What's going on? Is it a dark neighborhood? Is it a rough neighborhood? We really don't have that too much around here, but there's a possibility. We never know. So always keep that in the back of your mind. For the drivers, always park the unit to where we can get out, as easy as possible. I know that some of the dead ends, we don't have that luxury, but if we can, great. Law enforcement, what do they always do, guys? They always park right in front of the house. So normally what we have to do is we have to drive right to the next house right next door. So that's most of the time they are usually called out on all suicides. Let's see. Take additional steps for an unsafe scene. Remember, if it's an extrication, someone's trapped inside of a house, in a car, or whatever else, hazardous materials around crime scene, always preserve the scene as much as you can, especially if you think it's going to be a crime scene. They get very irate if we start disturbing a lot of stuff that's around and messing up their investigation. So try to be as safe as possible. On a vehicle accident, of course, we're always going to wear all of our gear, coats, gloves, eye shields, glasses again if we have to, hazardous materials. Again, you're going to do just the initial stuff that you have to, but just make sure that you are the #1 priority and the patient is always second.
And don't forget the safety vest on accident scenes, on car crashes, that you get your high-colored, bright-colored safety vest on.
Now, Captain Sousa, with that being said, what is the priority? What is the priority? Can we wear those over our jackets?
Yes. Those are designed to be worn either over your clothing or over your bunker gear, either one, but they're to be worn anytime you're out in any kind of traffic, those are to be worn. And they are to be worn over your bunker gear.
Okay. So if we have to do extrication, we have to put those on over our jacket.
Over your jacket, so that everybody sees you.
Okay.
That's why they're so large, so they'll fit over your coat.
Okay. Very good. Okay. Next, with MOI and NOI, okay, you're going to look for mechanism of injuries, whether it's a trauma patient, fall, shooting, stabbing. You're always going to do that. You're going to potential life, the serious of an injury. How much force was applied? If it's a vehicle accident, if it's a fall, if someone was stabbed, the length of the time the force was applied. How, if something fell on them, and a car or whatever else, somebody was jacked up on the car and the car was on them for 5 or 10 minutes, or 30 seconds, who knows? So think of that when you go there. The area that it was involved, did it involve the legs, foot, arm, the abdomen, the chest, the head? Always keep all this stuff in the back of your mind of what was actually involved when you think of mechanism of injury. Also, when the nature of the illness is mostly what we go on medical calls. Okay, keep complete. Why are we there? Just because you get called for a cardiac doesn't mean that it's going to be a cardiac. It could be a respiratory. It could be vomiting with chest pain. Who knows? That's why you have to do a little bit of an investigation. Get in there and find out exactly why we were there. Okay, talk with the patient, family, or the bystanders if you're around. If someone knows this patient, always try to get as much of the history as you possibly can to find out exactly what it is, and go from there. Okay? Do not attempt to categorize the patient immediately as a trauma or medical, but mechanism of injury or the nature of the illness will help us prepare for the rest of your assessment. Okay? So think about that, guys. Think about, don't sit there and go, I'm going to a trauma call, this is what it is. It could be a medical call that turned into a trauma call. So, prepare yourself and do your assessment so then that way you can go, okay, this is what I have, and move forward from there. Okay? Number of patients. Normally we're going to have this on vehicle accidents or a fight in a bar room or even at a house. You could have had family members that got into a altercation. Who knows? What it could be about. So always determine the number of patients. Sometimes ECC knows, sometimes they don't. So we got to think about that. Triage your patients if you have multiple patients. If your officer or your first-class firefighter or whoever else is going to run around, try to not tunnel in on the most severe patient. Okay, look around, go, okay, I'm going to check this patient, and then we'll run off to that one. If there's multiple patients and you and your officer or somebody else, you go around, hey, I've got a priority 1 patient here, a priority 2, or whatever else. Okay, let's all work on this patient. Get your triage tags out of the trucks and do that if you guys are the first ones on scene. And then, of course, never be afraid to request additional help, whether it's another unit from our department, whether it's another unit for EMS. Okay, it never hurts to call for another rescue. Okay, if you need another rescue, call up ECC and tell them, hey, send me another rescue. If they ask why, hey, I've got 3 patients here, and then let the on-charge medic, once he gets there, determine, hey, I can handle the other one, don't worry about it. Let them make that. But if you guys feel like you need another ambulance, go ahead and call one. Okay?
I'd like to say, the only thing I'd like to say is, as far as mass casualty plan, we have in the MCRRG the triage plan, and it probably wouldn't hurt for you guys to pull it out of the operating manual. There's one in each station, and review with your crew on how to do basically a triage of a single patient using the mnemonic RPM. So that could be part of this training, is to pull out that plan with your crew, go over how you would do the RPM and how you would give the people the color tags, whether they get a red, a yellow, or a green or a black tag. All right, I'm good.
Okay. And like we said, we already touched on this. If you need additional ambulance, an ALS unit, of course, all the units are ALS. Captain Sousa, are we allowed to request for a helicopter?
What you can do is, in the back of our BLS protocols is a set, it's called the Trauma Alert Criteria for adult and pediatric. And in our protocols, our BLS protocols, it does allow you to tell ECC, based on that protocol, whether you have a trauma alert or not. And it's specific. In other words, if you read that protocol and you have someone that's over age 65 and they're breathing greater than 30 times a minute and they have a significant mechanism of injury, those are 2 blues, which would mean a trauma alert. You can just tell ECC from 141 or 111, we have a patient that meets trauma alert criteria. And it's up to them to decide whether or not to call a helicopter. But what I would suspect is that the MedCom will get on the radio and say, ECC, get the helicopter there based on based on trauma alert criteria. You do not use paramedic judgment, because you're not paramedics, and that one, we'll reserve that for EMS. That's kind of a type of trauma alert that's called when there's a gray area. But if you know the trauma alert criteria in the back of our BLS protocol, you run on scene and see someone that meets that criteria, it's kind of obvious, call it a trauma alert. Just say, ECC, we have a trauma alert. And then they will then make the decision on whether to call the helicopter or not. And
remember, guys, they may ask for your identification number. Just like if we cancel a unit, they ask for your request an ID number. So kind of keep up to track. I know that they change here and there, but I know that Chief Pollock keeps them up to date pretty good. So just be prepared for that as well, okay?
An example, if you roll up on scene, I'm going to give an example. Someone is unresponsive, they're entrapped, they're breathing, and you have a pulse, but that's about it, and you can obvious signs of serious injury, and EMS is not there yet. Yeah, call it. By no means just go ahead and get on the radio and say, hey, we have an entrapped patient, unresponsive, meets the trauma alert criteria, and then let them make the decision whether they're going to call the helicopter. I've heard a few cases where fire departments got on scene on MBAs, and they gave a good description, and the MedCom went ahead and launched the helicopter. So it's good for patient care.
Okay, and then we have special rescue or extrication. Remember, we can call for heavy rescue out of Bradenton. The hazardous materials team, we have the trailers that are around. We can get those. Search and rescue, as you can call Paul if you will. But we do have our search and rescue team, and of course law enforcement. Don't be afraid that on an EDP patient or someone who's overdosed that is irate, don't be afraid to hit your emergency button and get them there a little bit quicker if you guys feel like that you need them there. Okay. C-spine immobilization. All right. If you suspect someone that does have a C-spine immobilization, remember, once you grab C-spine, you are stuck unless you pass it on to someone else. but you can't just let go of it and go, hey, you come here and grab a hold of it. Once you grab C-spine, whether it's your officer, first-class firefighter, you are stuck. Okay, so the reason I'm stressing that to, the first class and the lieutenants, because a lot of times, we may go up there and grab a hold of C-spine, and boom, it's there. You're stuck there, and you can't let go of it to go, hey, you go over and grab it. Now, if you want to, if we're there or whatever else, and myself or Captain Jasinski grabs a hold of C-spine, and we have a reserve guy, hey, I need to do a little bit more work or whatever else, you bring him over, have him slip his hands in right beside yours at the same time, never let go of C-spine, okay? Always err on the side of caution when you're immobilizing a patient, okay? It's better to immobilize this patient than to turn around and not do it and then something other happen later on, okay?
I think we got the video.
Yep, we got a video here, and it's a short little 2-minute video.
Turn it down a little bit. Okay, we're back on. Sorry about that video. It didn't really have anything to do with this lecture, but we'll move on. It was a quick review of recovery position.
It looked pretty good on when we first looked at it, but okay, general impressions. Okay, when we get to one of the first things that you're going to do is you're going to look at you're going to assess your environment, whether or not you're outside, whether or not you're inside. That sometimes will determine on what the patient's going to look like, what may be their problem. Who knows? So always assess your environment. Consider the patient's chief complaint. Look at signs and symptoms. Remember in Modular 1 when we went through baseline vitals and sample history, some of you have done it, some of you haven't. Okay, a sign is something you see. Okay, it's something physically that you can see wrong with this patient, whether or not they have vomited and you can actually see it on them, or if they're still doing it, whether or not they're sweating. Those are signs. Symptoms are something that the patient will tell you if they're dizzy, if their chest hurts, if their arm hurts, back, whatever it is. So keep that in mind. All right. How does your patient look? Again, like the picture shows right here. This patient's leaning down off to the side. We don't know what's going on. Did he fall? Is he passed out? Who knows? Look for NOI and MOI. Again, did he fall? How far did he fall? Was he standing up there? Was he pushed? Was he stabbed? Who knows? And then again, if there's any bystanders or if the patient's able to talk to you, let him talk to you. Let him tell you what's going on, or ask the bystanders. Maybe someone knows. Take a note of their age, race, and gender. Okay, elderly, young, female. Okay, so go through that. Chief complaint, most serious thing the patient is concerned about right now. Just because you get called to a chest pain, is that the most important thing that they're complaining about? Maybe they're complaining, well, I'm really hurt, my breathing is what's really bothering me right now. So let's focus in on your breathing. Let's get that fixed. Then maybe after your breathing, maybe that will correct your where your chest won't hurt you as much.
One thing I found is on determining the chief complaint is it's as you get more experienced at asking patients questions, you get really good at letting them tell you what's wrong. The inexperienced medic, basically, or the inexperienced EMT will put words into people's mouths, and next thing you know, they're complaining of everything you're telling them to complain about. So it's really important not to prompt the person too much. In other words, let them tell you what they actually feel without you having to prompt them. Like, are you having chest pain? A better way to put it is, are you having any pain anywhere? And then let them tell you where the pain is and actually make them point to where it is. Don't assume automatically that, when they say, when you say, are you having any chest pain, they're going to say yes, and then if you never follow up on where that pain is, it could be in the upper right shoulder area, not even associated with the heart. But we automatically will think when someone says chest pain, they think it's heart, when in fact it could be not related to the heart. So it's very important in how you word your questions about determining chief complaint.
Okay, and that touches on it. Most people may not be the most serious thing wrong with them, like he said. So, okay, assess your mental status, your AVPU scale. Okay, everybody knows what the AVPU stands: alert, pain, verbal stimuli, unresponsive. Are they alert to you? Do they talk to you when you approach them or when you talk to them? So then they're alert. Or is the only way that they respond to you is by pain? Remember, we don't do this sternum rub anymore. Okay, they basically push down on the chest a lot. A lot of the old school guys, we still do it a little bit, but in the picture here, they're pinching on the ears. One way that you can tell, again, too, is if someone's painful stimulus is if they're unresponsive. Take your hand and move it across their eyelash on the eyes. If their eyes are twitching or whatever, a lot of times that could be they can be faking. Okay, and then of course if they're completely unresponsive, that would be then of course you're going to follow the steps. You're going to go from there, whether or not you have to assess their breathing or CPR or what is needed from that. Okay. So remember AVPU. It's a pretty easy one that we use. Okay. And then, of course, you do your PPTE, which is you evaluate your orientation. If the patient is able to talk to you, ask them their name. Who are you? What is your name? Okay. Where are they? Do they know where they are? A lot of times after an accident, sometimes they may be confused. Well, I'm not. Ask them, do you know what city you're in? Oh, yeah, I live in Bradenton or wherever else. What time is it? Oh, it's mid-afternoon or it's nighttime. A lot of times, again, you can ask the year. What year is it? And then the event. Do they know exactly what happened to them when all this happened? Was it a vehicle accident? Did they fall? Whatever caused them for us to get called there, hopefully they can elaborate on that and let you know. Okay?
Can we go back to that one
Sure.
again? Anyone that has an abnormal mental status, you need to rapidly complete the initial assessment, be prepared to give high-flow oxygen, consider spinal immobilization, or if trauma is suspected, and initiate transport. So in other words, if someone doesn't have an alert, they're alert and oriented, and they're disoriented, you need to think of things of what's going on, MOI or NOI, to go ahead and start your treatment right away after that evaluation is done. That's it. That's all I had to offer.
All right. Okay, assessing the airway. Again, we're going to look for signs of the airway problem in a responsive patient. 2 to 3 word dyspnea. Can they only get, my name is, or whatever else. So you got to think about that. Are they having trouble breathing? Is this something where we may have to help them by bagging the patient? We don't know. Retractions, are they having a lot of trouble breathing? Those are some. Are they using accessory muscles? Are they using more of their diaphragm to help breathe? And their chest muscles. Are they in and out, in and out? So look at that. Signs of problems in an unresponsive patient. Obvious trauma. Excuse me. Is there blood in the airway? Mucus? Who knows what's in there? So again, that's going to be your suctioning. Noisy breathing. Is it noisy breathing because they have secretions or whatever else in their lungs, or is it because of something else? Shallow or absent breathing. Again, if they're real shallow or whatever else, we may have to assist them. Or absent altogether. What are we going to do? We're going to bag. Okay. And then again, if it's absent, we're going to take our OPAs. We're going to insert our OPAs, and we're going to bag the patient if we have to. And again, just to reiterate, we size an OPA by the corner of the mouth to the earlobe. Okay. So those are some things that you have to do when you assess the breathing. Okay. Make sure your airway's open. Okay. Make sure you're going to look, listen, and feel. I know a lot of times, and myself included, you don't always get down like we do when we're training out here and look, listen, and feel. But if you have someone that's unresponsive and shallow breathing, that would be a good idea, because there's a lot of noise going around, especially if it's in a house or whatever else. People talking, you need to listen. Try to see what you hear. Okay? So get down there and look, listen, and feel a little bit. See whether or not they're breathing adequately. Normal respirations are 12 to 20 times a minute. Okay? If it's less than that, you may have to assist them. If it's more, you're going to have to slow the breathing down. Okay? Look for cyanosis around their lips. That's a real good sign that they're not perfusing very well. Okay? Ask yourself the following questions. Does the patient appear to be choking? Okay? Are they choking on trauma-related? Something that happened in that aspect, okay? Then, of course, we're going to try to do suctioning or whatever we can do there. Okay, is the respiratory rate too fast or too slow? We have to correct it, okay? Get them to slow down. One good way that when someone's hyperventilating, to get them to slow down is put an non-rebreather mask on them, but don't give them 10 to 15 liters. Give them only 6 liters. Don't give them all that oxygen. Make them slow down their breathing. That claustrophobic right there may be able to be enough to slow their breathing down. Okay? Is the patient's respiratory rate shallow, or is it deep? Or do they have to breathe real deep, or is it real nice and shallow to where that it's hard for them to breathe deep? But if they breathe shallow, maybe they have pain in their chest somewhere, so that's why they're breathing shallow. Okay? Cyanosis around is the patient cyanotic, the patient blue. You have to correct it. Abnormal lung sounds. How many of you actually listen to lung sounds? I know, myself and a couple others, we do. Some people don't. They just wait until the medics get there and then go from there. But it'd be a good practice for everybody. Just after you take your baseline vitals, get your blood pressure, pulse, and respiration, go ahead and listen to the lung sounds. Take a quick listen real quick and see if you hear anything. If you don't, great. If you hear something other when the medics show up, hey, I'm not exactly sure what it is. I hear something other in the bottom, kind of sounds crackly or whatever else, pass it on. Okay? And then is the patient moving air in and out of the lungs, and then is the chest rising and falling? Okay? So you need to look at all of this stuff right here when you're assessing your breathing. All right. See. Let me back up right here real quick. I apologize on that. A couple other things. You're going to consider your supplemental oxygen. Again, nasal cannula, non-rebreather, or a bag valve mask. Okay? Again, nasal cannula, you're going to use it at 2 to 4 liters per minute. Okay? Make sure you grab an adult. A lot of times people grab the pediatric before you open up that. Take a look at it real quick. A lot of times they'll say adult on them. Make sure you grab a hold of that one. Non-rebreather is 10 to 15 liters per minute. Make sure when you take that out again, look at it. Make sure it's not a pediatric. That way, you don't grab one, open it up, it's the wrong one, throw it off to the side, and grab the other one. If you do happen to use a non-rebreather, open it up, hook it up to the thing, put your finger over the valve, and inflate that bag. so that bag is inflated. Okay, and then of course if you're going to use a bag valve mask, you know, crank that thing all the way up 25 liters, let that reservoir bag fill up, and then you're going to bag the patient. Okay, with respiratory rate greater than 24 or less than 8 is when you're going to start bagging a patient. Remember, a motto that a lot of the medics used to use, and I remember back in the day is less than 8, you're going to intubate. Okay, it's kind of a little bit of rhyme, but if they're breathing less than 8 times a minute, start bagging them. What I like to think of is if it's really about 10 or less, you're going to assist their bagging, or you're going to assist their breathing by bagging that patient. Okay, and any patient with a decreased level of consciousness, respiratory distress, or poor skin color should receive high flow O2. Okay, so do not withhold oxygen. And then a patient with no spinal injuries, we're going to do our head tilt chin lift if we have to. Open up that airway and get as much air in there as possible. Excuse me. Circulation, you're going to assess the pulse, rate and rhythm, and the strength. Okay, take a look at that. You know, you're going to feel a radial. If you don't feel a radial, where's the next one? You know, your carotid or your femoral. Okay, a lot of times when you go, if you can't feel a radial, what's the next place you go up to? You're going to immediately go up to your carotid. Okay, so and then again, is it bounding? Is it weak? Is it threading? You know, oh man, I barely feel it. What is it? Okay, and then of course you're going to count it either for 15 seconds or 30 seconds. If you do it for 15 seconds, you got to, whatever number you get, you're going to multiply it by 4. If you get it for 30, you're going to multiply it by 2. Some people still do it to where they count it for the full minute. Okay, and then of course in infants, which is 0 to 1 year age, you're going to check the brachial. Okay, now on some little ones, though, after they're a year old, they're still little enough to where you can still check their brachial. Like my little girl, Lexi, she's still a little bug. Okay, so I would still check hers. Even though she's 13 months old, I would still check her brachial because she's still small enough. Okay, so keep that in the back of your mind. Okay, you're going to assess and control external bleeding if you have to. Okay, that may sit there and help out with the circulation. Skin color and temperature. Okay, you're going to look at it. Are they pale, diaphoretic? You know, what is causing this? You know, why is it like this? Okay, fingernail beds. Well, on females, you have to remember, you can't really check their capri fill if they have fingernail polish on, so you might have to scrape some of that off so you can get a good reading or take a look at it. Skin color, you know, take your forearm, put it on somebody's head or on their arm, see what their skin color is, see if it's cool, diaphoretic, condition of it, you know, are they hot, what is it, okay? You can also check their eyelids, flip up their eyelids and look in there. Mucous membranes inside their mouth, see if they're dry. You know, see, you have all these tools that we've been taught, and a lot of times that we forget about them. But if you remember that, come back in there, pull open. If they're unresponsive, pull back their bottom lip, look in there. Is the mouth dry? That might be a sign of dehydration. Okay. Oh, I'm back.
Go back real quick.
Back
on the skin, on the skin color. The other thing is the conjunctiva area, the mucous membranes are going to look pinkish. Colors that should alert you would include blue, which would be cyanotic, or flush would be red, that would be like CO poisoning. Pale would be considered, there would be the skin would be all white, and then jaundice, they'd be yellow. Then you got to look at skin temperature. With poor perfusion, the body diverts blood away from the skin and directs to the core of the body. So someone that's really cold is going to be really white. Cool, clammy skin is an indication of hypoperfusion. So your skin color is very, very important. The skin condition would be determined whether the patient's skin is dry or moist. The skin is normally warm and dry. Cool, moist, clammy skin suggests shock. Heated skin, which is hot skin, may indicate abnormally elevated temperatures. And then capillary refill would be another indicator that we'd use. And what it is, it's the ability of the circulatory system to restore to the capillaries after circulation has been interrupted. Keep in mind that conditions unrelated to circulation may slow cap refill. One thing about cap refill is they found is that it's only reliable in children under the age of 6. So it's something that you shouldn't use in adults as a determination of perfusion. So if it takes longer than 2 seconds for the color to return in the nail bed, then they're considered to be perfusing poorly. If it's less than 2 seconds, then they're perfusing adequately. So that's your indicator on perfusion. Okay, John, I think we're done with that slide.
All right. Let's move on to high priority patients. Okay, these are some of the patients that you're going to think of as will be your priority patients. Difficulty breathing. Are they having a real hard time breathing? Are they choking? Did something other happen to that effect? Okay. Poor general impression. You know, when you get there, do they just basically look like junk? You know, what happened? You know, are they bleeding out? Who knows? Unresponsive with no gag reflex. Again, you know, when you get there, if they're unresponsive and they'll take an OPA, it's not a good thing. Okay. Chest pain with a systolic pressure of less than 100. Again, they're not perfusing real well. You're going to prop up their legs if you do not suspect any spinal injuries, and you're going to try to get that blood pressure up, and then go from there. Okay. There's not much more that we can do in a situation with, you know, because they're going to need IVs and they need to figure out what exactly is going on unless they have external bleeding that we can slow down. Okay. Poor skin color and poor perfusion goes right back into the systolic pressure. Those are some key signs right there that something's going on, whether they're shocky or what. Complicated childbirth. Luckily, I haven't run on any of those, but so I know that some of us have. Again, you know, if you get to a scene where a female is having a baby and she's been in labor for, you know, who knows, or if the baby's coming out breached, okay, that's a high priority patient. Uncontrolled bleeding. You can't slow the bleeding down, whether it's chest, abdomen, wrist, arm, whatever it is, okay? You're doing everything you can. That's a high priority patient. Responsive but unable to follow commands, okay? They're completely out of it. Stroke patients, a trauma patient who's been knocked silly. Who knows what it is, okay? But they are unable to count. A lot of times those patients may get irate and start fighting you, okay? Severe pain, chest pain, you know, when you ask somebody on a scale of 1 to 10, 10 being the worst, 1 being the least, it's a 10 plus. You know, I can't stand this or whatever else. Again, that's something that needs to be addressed immediately. And then your inability to move any part of the body. If they are completely numb, that they can't move anything. You know, hey, I'm touching you here. Nope, I can't move it. Okay, there's something going on. Okay, remember the golden hour, guys. When does the golden hour start? Okay, that starts immediately when the call comes in. Okay, so you got that hour. So there our time on scene, especially with a high priority patient. We got to get them identified as quickly as possible, and so either that way we can get them to the hospital or we can fly them out. Okay, and the time of the injury to a definitive care. You know, whether it be the Blake, Manatee, or Bayfront. All right, and then correct identification of the high priority patient helps us to improve the outcome. Okay. So if we hem-haw around for a while, you know, we're cutting into their golden hour to point to where it could be detrimental to that patient. Okay? I think we got another video here to start.
Okay, back on.
All right. Again, these are, you know, kind of, some of these videos are kind of generic, but they're pretty good. I'm not sure if I would necessarily put my straddle somebody's arm, because if they come to, you know, what's the first thing they do? They're going to pull that arm up, and they might kind of rack you a little bit. So just kind of be aware that it's there. But wasn't a bad video. Okay, focused history and physical exam. Okay, the decisions regarding the assessments are based on the two general conditions: your level of responsiveness to the patient and whether the patient's condition is a result of a trauma, medical, or a combination of two. Okay, so remember, like the vehicle accident we had in January, it was suspected that out on the causeway by Nancy Avenue Bridge, it was suspected that he might have had a heart attack prior to the vehicle accident. He had a lot of trauma, but was it because he had a heart attack or seizure prior? Okay, so think about those areas before you know, when you get there. Is that patient, did they fall because they had a seizure, you know, or different things like that? So think about those situations when they arise. Okay. Again, we're going to just kind of zip through these a little bit, because in Modular 1 we went through these with sample history and everything. Okay, our signs and symptoms. Signs and symptoms are what, guys? Signs are something that you see. Symptoms are what the patient tells you. Are they allergic to anything? Make sure you you get all that information prior to EMS getting their medications. If somebody can get their medications prior to EMS, that helps them out a lot. Sometimes it helps us out. Pertinent past history. You don't want to know that in 1972 they had a toe surgery. Okay, you want pertinent past history within the last 3 or 4 years, you know, that could be related to what's going on. You know, if they're out there, you're getting called for chest pain, and 6 years ago they had triple bypass. Okay, that's pertinent. Okay.
204. Dylan 204.
Sorry, guys. Last oral intake. You know, was this shortly after breakfast, lunch, or dinner? Okay, that's good information for the hospital, because if they have to go there and run tests, or if they have to go into surgery, they're going to want to know whether or not they're going to have a messy OR room. And then, of course, the events leading up to the injury or illness. OPQRST, the onset. Okay, when did it happen? Did it happen 5, 10, 15, or a day ago? Okay, what happened with that? Why are you calling us now for 6 hours ago when your head hurt? Okay, but that's what we're there for. Okay, the provoking factors. You know, what provokes it? Well, when I get up and go into the other room and sit down on this particular chair, or if I move my arm this way, this is what provokes the factors. And then the quality of pain. Okay, again, that's on the scale. I like to think that one as on a scale of 1 to 10. 1 being the least, 10 being the worst. Okay, and the radiation. Does it radiate anywhere? On chest pains, you know, does it radiate to your left or right arm, to your jaw, whatever it is? Like he said before, though, don't give that patient, when you're asking that question, don't sit there and tell them, well, does the pain radiate to your left arm? Why, yes, it does. Let them tell you, does it radiate anywhere? You know, does the pain go anywhere when you take a deep breath? You know, does the pain hurt more in your stomach or what? Okay, the severity of it. That's what I'm going back to. I apologize. Severity, that's on the scale of 1 to 10. Okay, 10 being the worst, 1 being the least. You know, and that way that gives the medics a good idea of when we got there, you know, 5 minutes ago prior to you getting there, they were an 8. We put oxygen on them. We took a blood pressure. You know, we've been talking to them. Now, when they ask them that if it's down to a 5, okay, that means it's coming down with some oxygen or whatever else. Okay, that's good. You know, maybe they won't have to do so much drugs or whatever else.
Quality of pain is like they tell you that they have a sharp pain, they have a dull pain, or they have an aching pain. That would be kind of what we've used for quality of pain, and the severity is what John just went over, 1 through 10. Okay.
And then, of course, the time. You know, how long has it been going on? Has it been going on for 5 minutes, 10 minutes, a day? You know, a lot of times we get calls in the middle of the night. Well, you know, my foot's been bothering me for 12 hours. You know, well, why did you have to call us at 3 o'clock in the morning? Well, I can't sleep. But a time, again, you know, that could be, you know, it could be a good tool for them to figure out, you know, whether or not they can get them to the cath lab or stroke or whatever else. So that's a good idea to get, you know, about how long it has been. Baseline vitals, okay? You're going to document your vitals every 5 minutes for critically patients, and of course on stable patients it's every 15 minutes. Okay, we shouldn't have to touch on that too much. Again, when you guys get there, kind of take a look at your watch. I just got vital signs. You know, if you got a medic unit that's coming the way or out, you might have to get another one before you got there, before they get there or right when they show up. Okay, here we go to our rapid physical exam. Okay, your DCAT BTLS. Okay, your deformities. You're looking for any deformities that you see in their chest, in their arms, pelvic, lower extremities. Okay, contusions. Did they fall off? You know, was it on a motorcycle? Did they fall? You know, look for contusions on all over their body. Abrasions. Was it when they fell? You know, did they scrape up and mess up their elbows, their hands, their knees, whatever it is. Punctures and penetrations. Okay, when they fell, did anything stab them? Did anything go into their arm, chest, back? Who knows? Burns, of course. You know, you're going to look through those. Tenderness. As you palpate this patient, is anything very tender, especially in their abdomen, chest area, different things like that. Lacerations. Again, do you see any big lacerations? Small cuts here, small cuts there, and then of course swelling. Okay. A lot of times you'll be able to see your swelling around, you know, if you have a broken arm or in the elbow or knee area, okay? And just because it's swollen doesn't mean that it's broken, of course, but, you know, it's good still to stabilize it, okay? You should perform this as quickly as possible. It should be 60 to 90 seconds at tops, okay? And the goal, let me go back here real quick, I apologize. Your goal is to quickly identify the potential for hidden hazards, okay? We can't always see everything, so, you know, we're going to quickly identify as much as possible, all right? And they're usually performed on trauma patients with significant mechanism of injuries, or you're unresponsive, that they can't talk to you, okay? Or a medical patient, okay? You don't know whether or not this medical patient, you know, they fell out, okay? Well, you get called for a cardiac and you get there and they're unresponsive. You still need to do a rapid physical exam on them real quick, guys, okay? Because you don't know whether or not somebody beat them down prior to you get them there. Who knows, okay? So don't be afraid that on a mechanism of injury or on a unresponsive medical patient to do a rapid physical exam. You still need to locate and identify anything that could be going on, okay? Now, steps for... Let's go through the steps for a physical exam. Okay, you're going to look for your head. You're going to use your DCAT, BTLS, and crepitus. You're going to look in the neck. You're going to look for jugular vein distension or trachea deviation or crepitus. Okay, you feel around through there. Remember, excuse me, when you do the neck, if you have the ability with the third or fourth person or whatever else, after you check the neck, go ahead and throw a C-spine or a C-collar on them. Okay, that way, whoever's holding C-spine, that's on and it's done. Okay, then you're going to start at the chest. You're going to feel the clavicles. You're going to go through the mid-sternum. You're going to look paradoxical motion. Okay, you're going to let them take a deep breath in and out. Do you feel any crepitus? Listen to the breath sounds on both sides. Okay. Now, when you get to the abdomen, okay, if someone is telling you that they have pain in their lower left abdomen, don't start there. You start on the opposite side. Okay, and then you do that and you leave that area for the last. Okay, so you start in the abdomen. You feel for rigidity. Or is it firm? Is it firm? Is it soft? Or is it distended? Okay, the pelvis. Remember, we don't do the pelvic rock anymore. We gently compress it downwards, and then you push it in for inwards, and then you feel whether or not that's stable or not. Okay, or if somebody complains if they're awake and they complain when you put on it, if you push on it. And then, of course, your extremities. You're going to go down both legs. You're going to feel it. Don't forget to feel for pedal pulses. Okay, if somebody has shoes on, take those shoes off and try to feel for a pedal pulse. If you've got time real quick, make an X on it right there where you feel it. That way you can immediately go back to that area and feel for it. And then, of course, check your cap refill. Go back up to your arms, okay? Down both arms, cap refill, check a pulse. Good. Maybe even ask them, hey, can you wiggle your fingers for me? Good. Okay, you got it. Then, before we put them on the backboard, you're going to roll them over, and whoever's in the middle is going to check that back. Okay, they're going to lift up their shirt or whatever else. They're going to feel down their spine. They're going to fill up their back, They're going to feel their back all the way down, and then, of course, they're going to check for their buttocks.
Can I follow up on something here?
Sure.
This is all protocol 1.2 in our medical protocol on page 6 on initial patient assessment. Everybody needs to get this out as part of this training and review the procedure for scene size up, initial assessment, ongoing assessment. Everything that John's talking about right now is covered on one page in that protocol of what we need to make sure that we do in the order that it should be completed. So it's important that you get the protocol out, review initial assessment on all patients, you know, and everything John's saying, general impression, mental status using the AVPU, mechanism of injuries, you know, stabilize the C-spine, assess your airway, breathing, circulation, disability, expose and examine head, neck, chest, abdomen, pelvis. Exactly what John is going through, looking for decap BTLS. So everything is in our protocol, what we're talking about right now. Go ahead.
Okay. So again, touch base on all that and keep up to date on that. Focused exam, okay? Then we go back, okay, guys, we're just touching back on this again, okay? You're going to look for the significance of your MOI, all right? You're going to perform your rapid trauma assessment. You're going to take baseline vital signs. You're going to obtain a history, and you're going to reevaluate for transport decision, whether or not they need to be taken now, if you have multiple patients, or, you know, you can wait until the other another medic unit gets there, okay? And if there's no significant MOI, you know, assess chief complaint, you know, do a focused assessment then, okay? And we'll touch on that here in a few. Take your baseline vitals, obtain your history, and then reevaluate for transport decision, okay? Usually, you know, you perform a trauma patient without significant mechanisms of injury or responsive medical patient, okay? Chest pain, look for trauma to the chest and listen for your breath sounds and obtain vital signs, okay? Short of breath, look for signs of an airway obstruction. A lot of times at these nursing homes, you know, if it's during dinner time or whatever, that may be a reason. Maybe they choked on a little bit something earlier. They thought they got it out, but they didn't, okay? As well as trauma to the neck or chest. Listen to breath sounds, okay? This would be a good time. Some of us do, some of us don't. Listen to those lung sounds when you get a chance. You know, get yourself acclimated to those, okay? See if they're assessing the signs or inadequate breathing. Obtain vital signs and ask the patient if he or she is having chest pain. Remember, if you're having chest pain, don't sit there and go, well, does it radiate to your chin? Does it radiate to your arm or whatever else? Abdominal pain, look for trauma. You know, is their belly is distended? A lot of times with an obese patient, you might not be able to see that as much, but you know, you might be able to. They may be able to sit there. You know, if you have a family member, whatever, you know, maybe kind of ask them, have an officer or whatever else for, you know, is their stomach usually that distended, especially if they're having, you know, something other going on in their abdomen. Palpate for tenderness, rigidity, or guarding if the patient's guarding, okay? Is any pain associated with bones or joints? You know, a lot of times, you know, that happens. Expose the area if they are. Check for a pulse, you know, your motor sensations, and then go from there. And then, of course, dizziness. You know, again, go back to your AVPU on that one, and then check vitals, okay? Steps for your focus history and physical exam is your 3 components. This is your next one here. Okay, you need your baseline vitals, your sample history, and your rapid and focused exam. That's what you're going to do. And then order will determine on whether or not the patient is a trauma or medical patient, and then the type of trauma or type of medical patient that it's going to be. Okay, so you guys going through and getting as much information as you possibly can is going to be able to set and determine on what's going to go on with this. Okay. Your focus and history physical exam. That's for medical. Did I skip over trauma? No, that was your trauma. There we go. Okay, your medical. Okay, again, responsive patient. You're going to check for, you know, their chief complaint. What are they telling you? Just because you get told for a respiratory doesn't mean it's a respiratory. It could be something completely else. The history. You know, what do they normally have a history of cardiac or respiratory? Get as much of your sample history as you can. If they're not able to tell you, bystanders, family, or whatever it is. OPQRST, your vital sign, and reevaluate. An unresponsive patient, you do a rapid medical assessment, try to get as much as you can, okay? Baseline vitals, sample history from family or bystanders or somebody knows them, and then your decision of whether or not how you're going to transport. Again, we're not going to be doing the transport, but maybe we can sit there and go, if it's an unresponsive patient to where if it meets trauma criteria, we can advise ECC so that way on the incoming medics know, hey, you know what, I got something that I may need to fly out or I may need another unit.
Let me talk about that real quick. On Protocol 7.3, which is our medical protocols, it's on page 68, it basically says, on occasion when Manatee EMS is busy or delayed response, the need for prompt care of a trauma patient should not be compromised. WMFR personnel can help shorten the golden hour by early patient assessment and notification of a trauma alert. To ensure that the condition of all trauma patients, both adult and pediatric, is assessed by EMT or paramedic utilizing methodology described herein, which is the state trauma criteria. Upon arrival, the procedure is upon arrival, location, and an incident, a West Manatee EMT or paramedic shall assess the condition of those injured persons with anatomic physical characteristics of a person of 15 years of age or older for the presence of at least one of the following 3 criteria to determine trauma alert status. The criteria shall be applied in the order listed. When the assessment is completed and it has been determined that MCMS may have a delayed response of at least 5 minutes, the on-scene charge EMT or paramedic will notify ECC by radio on Group 11 or established operations channel of a trauma alert utilizing the words trauma alert. So it's actually in our procedure that you are authorized, if Manatee is going to be delayed, to be on scene to give a trauma alert over the radio. John, when we do the practical, we'll make sure that you review the trauma alert criteria with everybody, and actually they'll be part of our skills evaluation. We'll be evaluating patients with trauma alert criteria.
Okay, sounds good. All right, so guys, remember, just to reiterate, okay, remember, a lot of times, a lot of the medics that are around here are so used to other departments that don't like to do anything, okay? But we have a pretty good reputation around here of going a little bit above and beyond, to help out the medics and take care of our residents within our community. Okay, so take that little bit of extra step and go that extra mile and try to get as much information as possible. Okay, because that not only does it help us, but it helps the medics, and it makes us look a lot better to when the other medics come in. They enjoy working with us. Okay, a detailed physical exam. Okay, you're going to perform only on stable patients and the problems that are identified that are not identified early. Okay, and those are usually done during transport, or if once you're on scene and the patient is stable, then you can go through and do a detailed physical exam. Okay, some patients may have life-threatening conditions, and you may spend all your time on just doing ABCs. Who knows? Okay, and that's fine. You may not never know that this patient had a tib-fib fracture or a femur fracture, okay? If all you're doing is ABCs, then that's the priority. That's what's going to keep them alive, okay? So you may not ever know about anything else, especially if there's a problem with any of their ABCs, okay? You're going to reassess their mental statement, their status, okay? Always asking, hey, how you doing? Do you know why we're here? Maintain the airway as long as they're talking to you. They have a good and patent airway. Monitor their breathing. Does their breathing slow? Go fast? Does it slow down? Who knows what's going on? Reassess their pulses. Okay, leave that pulse ox on there. Take a look at it every now and then. Look at it. Is it going up? Is it going down? Especially when you go into a house that there's activity going on. Sometimes when a certain individual's in the room, their pulse may go up, and then when that person leaves the room, whatever, they may calm down a little bit. So kind of keep that in mind. Skin color and temperature. Again, reassess that. Establish a priority. Okay, what's going to go on with that? Is it priority 1, 2, whatever it needs to be. Reassess the vitals every 15 minutes. Every 15 minutes, if they're stable, and it's every 5 minutes when they're not. And repeat focused assessment and check for interventions. Okay, see what we're going to do. Okay, your detailed physical exam is you organize by body region. You visualize and palpate during DTLS. your head, and cervical. Check the head, face, scalp, ears, nose, mouth, abrasions, lacerations, and contusions. Okay, you're gonna feel them. You know, get your hands on there and see what's going to go on. Okay, use your pen light that's in there. Okay, take a look in there. Get used to that pen light working in there. A lot of times when you're out in the field or whatever else, and if it's sunny out, you may have to put your hand or something else over the patient's eyes to get them work a little bit better. Okay, look for any fluid drainage around the ears or the nose. Look for bruising, lacerations, depressions, deformities. Okay, palpate for tenderness and deformities and instability. Look and feel inside the mouth. I don't know if I'd go inside the mouth, but you know, look in their mouth. Okay, you don't necessarily. I wouldn't stick my finger in anybody's mouth, you know, but maybe ask them, look in there, see if you see any broken teeth or whatever else. Okay, smell the breath, especially on on a blood sugar patients. How do you say that word there, Cap?
Hyperglycemia?
Hyperglycemia, you know. Think of those patients, okay? Is it a nice fruity smell? Okay? Look and palpate the front and back of the neck for tenderness, okay? Look for pronounced or distended jugular vein distension, okay? Chest. Again, you know, guys, this is all stuff that you do in your rapid, but now you're taking a little bit longer than 60 to 90 seconds, okay? You're going to monitor their breathing, okay? You're going to look for equal chest rise and fall. You know, you're going to feel their chest. On females, of course, you know, you go down the center and then you go up and underneath the breast, you know, and excuse me, you know, and let them take a deep breath for you and see whether or not you feel anything abnormal in there. Listen to the lung sounds a little bit, you know, better. You know, go off to the sides, auscultate on there, you know, upper chest, you know. Listen at the base and aspects of the lungs, okay? Abdomen, you're going to look for obvious bruises, deformities, anything like that. Palpate for tenderness. Again, if someone's complaining for a certain area, you avoid that area for last. You always start on the opposite side and away from it. Okay, so if it's a lower right, you start in the upper left, and then you move on from there. Okay, pelvis. Again, we don't do the pelvic rock anymore. You press down gently and you press in gently. All right, see if they complain about that. And then, of course, your extremities. You go all the way down, feeling for palpating all the way down. Again, pedal pulses on there. If you can find them, mark them with an X. You know, cap refills. And then, of course, your upper extremities. All the way down, feel for a radial pulse, cap refills. Okay? And then, of course, look for any other abnormalities that you may find. Okay, and remember, on many trauma patients, you're going to do the spinal precautions. Okay, when you log roll the patient. All right, and then of course you have your ongoing assessments. Remember, guys, that's the ongoing stuff that whether or not you're doing the transport with the medics, or if the medics are far out and you got one that's coming from East County or whatever else, you're going to do it. Stable patients again, 15 minutes. Non-stable, it's every 5. You know, and then take notes. Is your treatment helping this patient? You know, by you laying down this patient that was having chest pain or whatever else, did that help their blood pressure? Aspirin, you know, if somebody is complaining that and you gave them 2 aspirins, did that help out anything? Did the O2 you give them, did it help? Yes or no? Hey, I had them on a nasal king at 4 liters per minute. That didn't do anything. I'm going to bump them up to a nasal non-rebreather. All right, that helped. And then, of course, you know, you're going to continue to check on your blood pressure and see whether or not by laying them down, if you elevate the legs or whatever else, if there's no spinal injuries, if that helped anything. Okay? So as the ongoing assessments are going to continue, you're going to continue those until the medics get there and until they take over patient care and they release you. All right? Anything else, Captain?
Just a quick review on the protocols. 1.2 initial patient assessment. I'll probably have some questions on the proficiency exam on that. Also, I'm going to include some stuff on 6.7, which is multi-casualty. There'll be some questions on that in regards to doing your initial assessment on a trauma patient to determine their category of triage. And then the trauma alert criteria. There's actually protocol 7.3. I'll probably have a few questions on that also. And then John will be coming around in a few weeks to each station and he'll be doing a hands-on skills evaluation where you actually get to practice, what we've been talking about as far as, scene size up, your general impression, rapid physical exam, medical trauma patient, and then your packaging and all your steps and all that stuff. So I thought this was a good lecture for patient assessment, module number 3 for our continuing education program. Thank you very much, John.
All right, and we have one more video that we'd like for you guys to see on patient assessment, and this will kind of go on about what we're going to be looking for when I come around. All right, and after it ends, that'll be it. Thank you guys very much.